Really?
We're good to go.
Yep.
And happy Tuesday night. And welcome to our Crowfoot Village Family Practice live webcast on healthy brain aging. My name is Rick Ward. I'm one of the docs here at CVFP, and I will be the host and moderator for the next hour and a half of a topic that I think has gotten huge interest, which I'll come back to. First, I'd like to do is just do a land acknowledgement. In the spirit of reconciliation, we acknowledge that we work, play, live, and heal on the traditional territories of the people of the Treaty 7 region in southern Alberta. This includes the Blackfoot Confederacy, comprised of the Siksika, Piikani, and the Kanani First Nations. The Tsuut'ina First Nations and the Stoney Nakoda, which includes the Chiniki, Bears Paw, and Goodstoney First Nations. The Calgary area is also home to the Métis Nation of Alberta, districts 1, 4, 5, and 6. So here's what we want to talk about. We want to introduce through the next hour and so what the Brain Health Initiative is that Crowfoot Village Family Practice is starting up for patients. And there's sort of three pillars to the initiative. One is to talk a little bit about how you can maintain brain health and some specific things that you can do to prevent early cognitive or memory decline. Second is that question that I've been asking myself a fair amount in the last several years is, boy, is that forgetfulness that I'm having, is that like just being 60 something, or is it a sign of something more sinister? And finally, there are new treatments, new concepts on the horizon that we want to bring to our patients to talk about, because it does have an impact on how I think we will all look at brain health. I just want to start off with a couple of quotes that we received. We did a small survey of about 150 patients just to find out what was on their mind about brain health. And the question is, what's your biggest fear when it comes to brain health? And I want to read you a couple of the responses. My greatest fear regarding brain health is that I didn't follow adequate processes as I aged to reduce the risk of developing some degree of dementia. Another comment. My mother was diagnosed with dementia in her early 70s. I watched her ability to perform simple tasks decline. I've had a couple of episodes of my own behavior that have caused me concern. I'm worried about developing dementia. We had many other comments that were very similar about one, what can I do to prevent dementia, and the fear of developing cognitive issues that will be a burden to family. As we've talked about this program, everyone who I've spoken with and connected with has some personal experience in this space with a family member or friend. So this can be a devastating condition, and I think it's really timely that we're opening the dialogue. But hey, let me tell you about the all-star cast we've got. We've got Janet Reynolds as our leadoff hitter here. She wears many hats, both nationally, locally, and especially at Crowfoot Village Family Practice, where she's our medical director. My days go smoothly because of the fortune that I have working with Nurse Alex, also known as AJ. So I sort of slip back and forth between the two. So AJ is going to bring us some great pearls of wisdom from a nursing perspective. Landon Perlett, who is a neurologist at the Alberta Neurological Centre, will also be joining us as our I guess that's the cleanup person. Yeah, so number three in our batters list. Um, Dr. Perlett is really a rare breed of neurologists who specialize in cognitive health and cognitive medicine. So he is not just a local treasure, but really one of several dozen cognitive neurologists in Canada, and this is the space that he works in every day. So really fortunate to have him bring us the up to date on brain health. And we have our fearless leader, Shauna Tome, who is our executive director here at Crowfoot, who actually not only keeps us together and keeps us focused, has done a lot of work in her master's on brain health. So she really brings a cool perspective. In the wings, one of our young doctors, Dr. Ingen Benedictson, who is a relatively new associate. I think she's been with us 3 or 4 years and a trainee beforehand. Ingen moonlights at the Mint Clinic, which is a primary care network specialty clinic in memory. And so she's going to be manning the chat. Next slide, please, Trev, where she'll be answering questions on the fly. This is what the agenda looks like. We've got lots of time at the end for questions. We've had some submitted, but feel free to use the chat as the next slide prompts me. We're happy to do sort of interactive dialoguing things. So please feel free to use the chat. Ingen is going to be monitoring that as well. We've got pre-submitted questions. Yes, this will be recorded and it will be available on our website tomorrow. So if you want to go back and listen to some of the jokes and cool pieces of wisdom, it'll be on there. About these things, remember to subscribe. So if you want to be in the loop for more Crowfoot Village Family Practice webcasts, click on that I subscribe button in the bottom right or left, wherever it is on your screen, to keep in touch. Next slide, please. So I'm going to turn this over to JR, Dr. Reynolds, to maybe give us some background. So JR, what's brain health? Why are we talking about it, and why is Crowfoot going down this road?
Thank you, Rick, and welcome everyone. Thanks for spending your evening with us. I actually think we should maybe level set around what brain health is before we get into some of the detail, because I'm not sure we all understand what we're talking about, and it really does encompass brain function in 6 domains: motor, emotional, sensory, cognitive function, behavioral, and social areas. So a healthy brain actually functions well in all of those domains, and beyond just the absence of disease, I would say. And so we're getting better and better at, oh, the slides went away. Is that supposed to happen? We're getting better and better at understanding brain health and all of the different things that impact it. Once you get beyond, our basic needs like shelter and food, I would say. Your next question was why brain health? Well, as we do at CVFP, it's really a go big or go home, because as I just described, brain health is a really big topic, and but our brains are really important. So I think there's a demographic in our population that are aging, and an aging brain is more at risk for certain conditions. So we're worried about an onslaught of brain disease like dementia, and you'll hear throughout the webinar, we're going to talk a lot more of dementia and cognitive impairment, but that's one reason. Another reason is we have each other and this team, and we are a test kitchen where, as we understand newer potential treatments for dementia, we need to figure out how we can incorporate that a process into primary care. So we're really testing out, first of all, what will the demand be maybe, and also how can we integrate it into are already full schedules. Um, for those of you who don't know, if a family doctor did nothing but follow the guidelines that are relevant to family medicine, they would work 27 hours a day. So we really need to be judicious in how we incorporate this, and it is a really important topic. What was your other question, Rick?
Maybe just riffing a little bit. How frequently do you see patients that come to you that say, "I'm concerned about my memory. I'm concerned about developing dementia." Is that a common thing that you see?
Yeah, I would say at least weekly or multiple times a week for me, and I work 2.5 days a week, just for perspective. So it is a very common concern that's brought forward, and teasing out the who lost their wallet because they're distracted and who lost their wallet because they should know where their wallet is really can be really difficult.
And how do you see our approach changing as we're understanding more about cognitive impairment and dementia and memory changes?
I think what we're seeing is, and when we get to the next section, we'll talk a little bit about prevention. So a very significant landmark article that was published around the 12 things that are perhaps modifiable or controllable for us. You talked about being in your 60 somethings. Well, those of us in our 40s and maybe 50s are the ones that really are the ones who should be looking at these modifiable or risk factors that are in our control for dementia. Um, and I think so that's one. The new treatments that really are defined by early intervention, so making the diagnosis early. We unfortunately, for a long time in dementia, at least in primary care, it's been kind of a sad story where there's not much to offer our patients but planning. It's felt like the medications that have been around in the past haven't been as exciting or as useful as we would have hoped. And so it's been quite static. And now there's some really cool emerging things that Dr. Perlett's going to talk about. So I won't spoil it.
Yeah, no, I think one of the things that's prompted this work is a bit of a paradigm change in how we approach patients that self-identify or identified by family members as having some cognitive issues. So we are, I think, on the precipice of some change because there's a sense of nihilism, hopelessness, right? It's like, well, we'll see what happens, and often little that could be done to change the trajectory. So in many ways, I think it's a very hopeful time. Um, but you mentioned prevention and the stuff that's in our control, and Dr. Perlett is going to show a really interesting slide a little bit later in the webcast about sort of where in our phases of life we can make changes that will impact cognitive health down the road. So the prevention story really is an important one and a very cool one, and one that we're going to be embracing as part of our brain health initiative. JR, should we turn it over to Nurse AJ to get into that prevention mode?
Yeah.
All right. So the next slide just references really the start to our discussion around prevention. And really, this came from an article that was published in the Lancet, which really surprisingly suggested that a lot of the dementia cases could be prevented or delayed through targeting specific risk factors. In the next 20 minutes, we're really going to talk about those and talk about some resources that you can consider in that prevention realm. Nurse AJ, why don't we call on you to come off mute and join us and talk a little bit about some of the first preventative themes in this space.
Sounds good. You want me to talk? I don't really like talking. But no, really, I think any nurse and really our knowledgeable nursing team at CVFP has such a strong focus on health promotion. And so I think no better time than now to be talking about the things that we can do. And really, this is aimed at anybody, it doesn't matter how old you are, that we can do now and always to really strengthen our brain health. And because really, when we're taking care of our bodies and we're taking care of our minds, we're doing everything that we can to take care of our brain health. And there's no time that we shouldn't be doing these things, but really just a great opportunity to reinforce what we all should be doing to take care of our brains. So the first part would be, when I was talking about that, is taking care of your body. When we talk about taking care of a body, we can start with the heart. So with the heart health, really important, not putting too much strain on it. So making sure that you're having a good blood pressure, really looking off to the focus, having that systolic, that top number, be at or below the 130, and as well, in hand with that is making sure that you're having a good lipid or a cholesterol profile, which means really eating healthy. And I know a lot of people have a lot of different ideas about what that is, but one of the best things that we can do by eating healthy is looking at a Mediterranean diet, which no, unfortunately, doesn't mean we're doing a prescription to travel to Greece. But what it really means is really a focus on fruits, vegetables, fiber, and having poultry and fish with a less of a focus on meat, unfortunately. Tough in the Alberta thing, but there are certainly lots of options and lots of healthy, tasty options. And as well, when we're talking about taking care of the body, these are things that I don't think a lot of people really see as being part of that, but they're nice, easy things that we should be doing, which is taking care of our eyes, our ears, and our teeth. So making sure that you're getting your routine screening, your routine vision checks, remembering that those over 65 basic eye checks are covered by Alberta Health, getting your ears checked and your hearing. So again, lots of private hearing clinics actually do hearing tests for free. So, please don't let the cost be a barrier to taking care of your hearing, and dental checks as well is really valuable.
Yeah, AJ, when I was looking at this list, I think that the hearing one really jumped out at me as one that wasn't intuitive. And again, we'll see a slide a little bit later to show how critical that is. And you're right, there is lots of accessible places to get hearing tested. Yeah, great comments. Asking you about social interaction and how social interaction seems like a no-brainer. The social person that you are,
Yeah.
what can happen in that space?
So there's kind of two prongs to that. So we're thinking about those social connections. So making sure that you're reaching out, you're having connections with your family, your friends, and your community. So, being isolated really is unfortunately a detriment to our brain health. So, making sure you're getting out there. And again, talking about thinking about barriers. There's a lot of really great programs out in the community that are free or are very easily accessible through your library, through your community, even through the city of Calgary with 311 can get a lot of kind of great suggestions for great ways to reach out and participate in your community. And then the other thing is be a lifelong learner. And that's really just staying engaged, trying new things, just keeping that brain going and really challenging yourself. And again, there's just so many great ways that you can connect with the community and, just trying new things, exposing yourself to new things. It's really great way to keep those brain connections, keep your brain active, and challenge is really essential to overall brain health.
So there's something to be said for the Sudoku puzzles and Wordle and all those cool online apps.
Yep. And this is puzzle season, so go to town, but again, maybe do it with a family member or a friend.
Yeah, I just want to swing back to the social interaction piece. One of the things that I've noticed in my patients who are transitioning out of living on their own, particularly if they've lost a spouse, is there's always this big pushback and this big objection to moving into supportive living or assisted living. But boy, oh boy, that kind of transition can do wonders for people's mental health and their sense of social connection. I see with my own mom, she's not watching tonight, so I can tell a mom story. That her world as she's approaching 90 is becoming very small in terms of her peer group. The birthday girls that had gotten together once a year since she was in school, all of them have died and one has dementia. So it becomes a very small world. So I really highlight on that piece of social connection and even thinking about transitions in living.
Yeah, and it's not that you need to become a different person or change your personality. If you're an introvert or you're not really comfortable being in front of a bunch of people, that's fine. It's really just about creating those connections to your comfort level and finding those social connections and just really finding your place in there to really kind of help engage yourself and keep your brain active.
So Calgary in the summer, I see pollution is on this list. What the heck do we do about that?
Yeah, so definitely, still important to get out, to get active. And there's different ways that we can do that. Certainly this time of the year, my gosh, things are slippery. Please be careful. But whether that's exercising indoors, exercising in your home, when the weather is beautiful, please go out and get that beautiful fresh air. But just keep in mind, city pollution, and when we, unfortunately, with where we live, those bad air quality environments, definitely take them under caution and just maybe alter your plans for fresh air to maybe a different day when it is fresher, because certainly fresh air is important, and taking care of your lungs is, again, taking care of your brain.
Tell me about smoking and alcohol. I think the smoking advice around smoking is going to be a pretty black and white point. Eh?
Yeah, don't do it. Sorry, nope. And if you're watching this talk while having a glass of wine, maybe alter your plans. Really, abstaining from alcohol being, of course, the best thing and for your overall health, but really alcohol intake as part of that Lancet study did show it being something that can adversely impact brain health and is a risk factor for dementia. So, avoiding or abstaining from alcohol certainly is best for heart health.
Yeah, I want to put a plug in for smoking cessation. So for those of you who are smoking, obviously the best thing that you could do for your health would be to stop. The good thing is there's lots of tools to help, and those include both medication, nicotine replacement, but also some good resources for some tips on how to stop smoking. The alcohol story, I think, has changed. Back in the day, we used to say, oh, well, 2 to 3 drinks is actually good for you. I think we now recognize that there is no safe amount of alcohol, and that at best, cessation from alcohol, but moderation is always good advice. If you still want to enjoy a drink or two. And again, I'll be guilty as charged there, but the moderation piece is good. AJ, thanks. You've already noted that our great nursing staff spend a lot of their time talking to our folk about prevention, and this is really an extension of the work that you've been doing. Any last words that you'd like to leave us with?
Honestly, really, I think it's important for patients to advocate for their health, and by doing that, taking charge and taking control of the things that we can control, and taking those first steps towards, whether it's picking up a new book, joining a new club, or getting your ears checked. I think those are such important health promotion things that you can do for yourself that will impact your overall health, and as we look at this, brain health as well. And your body will thank you, and so will your nursing team.
Love it. And I think that message of patient empowerment, there's things that we can do right now to reduce our risk. And there's lots of resources to support that. Let's welcome back JR, who's going to do round out the list of prevention topics and strategies. JR, I know that Alex talked a little bit about blood pressure and cholesterol. Maybe we'll get you to chime in and maybe upvote some of those comments.
Yeah, and I think Trevor, next slide if you can. So you're quite right. AJ alluded to this, and I think what's cool about tonight's webinar is a lot of these things are motherhood statements like eat well, exercise, drink not at all or in moderation, and don't smoke. But we're reframing this as a way to give you back the control. And we're not that purposeful because we've been doing a lot of these things already. And basically what's good for your heart is also good for your brain. And we're um, just expanding on the heart health that we're all really well familiar with. So every adult over 18 should be screened for high blood pressure once a year. That's a Canadian recommendation, and that's another Go Big or Go Home initiative that we've undertaken at CVFP. And some of you might have our How to Screen for High Blood Pressure at Home guide already. Screening for diabetes can be customized or individualized, but that should start at age 40 and happen every 3 to 5 years. And we do that with a blood test. So just to be clear, screening for a condition means we're looking for it before you have any symptoms. So if you come in losing weight, drinking, being really thirsty, and having symptoms of diabetes, we would go investigating for it, but screening means you don't know you have it, but if we find it early, we can change the trajectory of that illness. Nobody knows if they have high cholesterol until they actually get a blood test or have an event that could be related to high cholesterol. And the reason that one's important is it's a number on a page, but it goes into a risk calculator for other vascular disease. And so the numbers on the page don't matter quite as much as how they all come together for you individually. And again, that screening happens starting at age 40 for the average adult every 3 to 5 years. We don't necessarily screen for mood disorders in our adults, but we definitely have relationships with all of our patients, and all of us who are family doctors love that probably the most of all in our jobs. And so checking in on how things are going, looking for things that are happening in your lives as you go through that journey of life, and managing mood disorders, whether they're chronic or otherwise, that's what we do. And trying to support you in getting good quality sleep is the last part on this slide.
Yeah, JR, let me sort of pick at a few of these. And I'm going to start with the heart in the middle, high cholesterol. As you know, I've been banging the drum on statins for some time now, and one of the biggest concerns, objections that I hear is, oh my goodness, statins cause dementia. True or false?
False. Capital F, false. That has been myth busted for some time now. And when I'm off as the main show here, I'll put a link in the chat or try to that will show people some of the myths about statins. Statins are probably the most commonly prescribed prescription medication in Alberta.
Yeah, and a question in the chat room. What the heck is a statin? Thanks for that question, JR.
So statin is a class of medications that are lipid lowering or cholesterol lowering drugs that, aside from reducing your numbers, have been shown, again, without a shadow of a doubt, to reduce events. So brain events like strokes or heart events like heart attacks. You're the expert, Rick. What else would you say about statins?
Yeah, no, and so these are drugs like atorvastatin or Lipitor, rosuvastatin or Crestor would probably be the two most common. Zocor, simvastatin is another one. So these statin drugs um, really are standard of care for anyone who's had diabetes over 5 years or who has diabetes and has an LDL which is above target. So
Or Rick, anyone who's had a mini stroke or a TIA or a heart event, or is at high risk for those
yeah.
because of other factors. Yeah.
So the cardiologist would say this should be put in the water, but I don't think that we're having challenges with fluoride, so I'm not sure that getting our statin in the water is going to happen. Um, just again, touching a little bit on sleep. What kinds of sleep issues might be associated with memory issues, mood issues? Talk to me more about the sleep connection in all of this.
Uh, Pass. I am not
Okay.
prepared for that question. So you're
Well,
prompting
why don't
me.
I sound,
Why don't you tell
why don't I
me?
throw my thoughts in there?
Go for it.
Although, and actually, might ask this to Landon, but sleep apnea, something that we recognize in association with a lot of chronic conditions, diabetes, depression, high blood pressure, is something that really should be considered. Especially for those people that snore through the night, that wake up unrefreshed, have excessive daytime tiredness, have good thick man-sized necks. So that's, I think, one thing that the spouse. I find that most of my diagnosis of sleep apnea are made by the spouse who says, "I almost called 911 last night because you weren't you stop breathing for 30 seconds in between a snore." Landon, maybe I'll just ask you to come off mute and throw that question to you. Sleep apnea and cognitive issues.
So this is becoming a hotter topic as we see, the cardiovascular risks associated with obstructive sleep apnea. It wasn't nearly this hot even when I was in medical school. And so if you think about it, while you're sleeping, you're actually trying to form and cement your memories. And if you are not breathing for periods of time, seconds, which add up to minutes over the course of a night, you are depriving your brain of oxygen and not really getting a restful night's sleep. And if you're chronically sleep deprived, of course, your thinking and memory and decision making are going to be affected. And we're seeing that this is an elevated risk towards dementia, let alone pulmonary hypertension or heart attack or stroke. It's a very easy thing to screen for. And I have found it in patients that are very thin and say that they don't snore. So I've been surprised with these findings. So if somebody has cognitive challenges and they tell me that they're having trouble sleeping or they're tired during the day, I just ask them to perform a sleep study, which they can easily do, and see what we're dealing with. Is it present? And if so, how bad is it? And it kind of gives them an idea of maybe this is something I need to look at a little bit deeper.
Yeah, so great practical tip. And what I'm hearing is that non-restorative sleep, waking up feeling like you could go back to bed, or excessive tiredness through the day would trigger you, even in someone that doesn't have the sort of physical characteristics of sleep apnea. But that would encourage you to screen those individuals.
I also just want to mention that there's more thought here that the abnormal proteins that build up in dementia are cleared in our sleep through our lymphatic system. So if we do not have good quality sleep, it is likely that those proteins are not being cleared from our brains productively or efficiently. And so I think sleep is a big driver for cognitive impairment and dementia. So I think it's becoming a hotter topic over time.
That's what I was going to say. Just kidding.
Thanks, JR. Modest as always. I think, no, and again, how common we see sleep issues during the day in the practice is, so it is an interesting area. How we screen for sleep apnea is through something that we call a SNORSAT test, which we can order through one of the private respiratory companies. So relatively easy to screen or investigate, I guess, JR, for people with non-restorative sleep that may have apnea.
We actually have that quick questionnaire, Rick, that also is a predictor. So that's the screening part, the stop bang. We ask some questions. Yeah.
Good stuff. Stand by for the stop bang. All right. I think that we have prevented most of the dementias, but it wasn't 100%. So I guess it's time to sort of move over to talk a little bit about differentiating early cognitive impairment from normal aging. But before, Landon, we get you to address that, I think that there was a couple of punctuation marks that you wanted to put on the discussion of prevention. And Trev, maybe we'll get you to go to that next slide, and I'll turn it over to you, Landon.
Alrighty, so this is a slide that's being added to over time. I think it's a few years old. This is a more recent one. And so there's different stages in life where we can impact somebody's cognitive abilities and risk of dementia. So obviously within early life, the more education you receive, the higher you have what is called a neurocognitive reserve. So you have healthier brain cells, larger volume of brain cells, and people with a higher level of education have less risk towards developing dementia. And if they were to develop dementia, they tend to worsen slower than those that have a lower educational level. This is the same with even people that may speak multiple languages. That seems to be another benefit for risk towards dementia. And then you enter into midlife, and this is where a lot of the groundwork should start to be laid if we are trying to target dementia prevention, which is near and dear to my heart, upstream medicine. I would rather deal with a dementia that's not there than a dementia that is set in stone. So there are many things, the cardiovascular health that you talked about. I want to mention hearing loss and vision loss. So if you think about it, if your brain is deprived of a function that it is doing constantly or most of the time, the brain doesn't really need those neurons anymore. So it starts to kind of prune the connections between them, and neurons slowly start to kind of die away. So screening for hearing loss, screening with annual eye exams can make a big difference. I know I have a lot of patients that have hearing loss and they don't actually wear their hearing aids. And it's very difficult to know if grandpa doesn't remember what was being said or never actually heard what was said in the first place and therefore forgot. So I think, these easy screening tools we have can make a big difference in people. And then in late life, as you mentioned, social isolation. They've done studies with different technology, like putting tracking devices in cars, monitoring phone calls and text messages in older population's phone. And if we start to see in older adults less communication with each other by phone or visiting with friends and loved ones, sometimes we will see a reduced driving radius around their home. So they're not leaving their home as often. They don't go as far as they used to. So these social strategies to help get people in to more socialization, day programs, and that sort of a thing in older life can make a big difference. So just knowing about these things and thinking about these things now, whether you're 20 or 40 or 60 or 80, they're important, and I just wanted to mention them.
And the next slide, I think, just highlights the cardiovascular side and also risk reduction by impacting the different modifiable risk factors.
And I just want to touch that obesity in midlife seems to be a big factor. So having an elevated BMI or being obese in your 30s and 40s is a significant risk towards developing dementia or cognitive impairment in later life. And it's actually worse in women when compared to men. Now, we don't know why that might be, but there is a obesity epidemic in North America. And I think, exercise groups and walking groups and all that can make a big difference in people. And so having regular physical activity laid down in your middle ages makes a big difference in your later years. Okay, yes. So the website. The website there is not quite correct. It didn't take me directly to this, but the American Heart Association does have a sort of cardiovascular health calculator. It's free. It's just a few questions regarding, how many hours might you be active physically? What sorts of foods are you eating? Are you smoking? And if so, how much? Are you drinking? And if so, how much? And so what you will get out of the end is a sort of list here, and your aim is towards a higher score. So anybody can do this on their phone or online. You just have to be honest with yourself when you're answering the questions, and then you might see, okay, my blood glucose levels maybe aren't great. I should start to work towards better diet, or my physical activity levels, looks like that bar is lower than I thought it would be, given that I walk a few days a week. Maybe I should start working on that. So I think it's a good tool just to quickly check and see, where am I lining up in the overall cardiovascular health? Because improvements by shades and degrees over years can make a difference in your later years. So a pretty cool tool. That website is not exactly correct. We may be able to share that later on.
Yeah, we'll be able to do that for sure, Landon. So as we sort of move from the prevention into recognition, diagnosis, and what we do about it, I think it'd be really helpful for the viewers to really maybe differentiate between dementia, Alzheimer's, minimal cognitive impairment. Are they all the same thing? Are they different? Help us understand those terms.
So maybe I'll start with a mild cognitive impairment. So this would be a person that has deficits in certain cognitive domains, whether that's their ability to speak, their ability to remember things, their ability to change tasks or make decisions, that would be outside of what is expected given their age and other health issues. But this person should still be able to function in their day-to-day lives. They would still likely be working. They would still be able to drive. They could access their bank accounts and pay their bills. They could cook a meal for themselves left on their own. So they're noticing some changes that are outside of the norm in their life, but their level of function appears, for the most part, preserved. Whereas a dementia diagnosis means that somebody has lost what we call an instrumental activity of daily living. So that is a learned task or something that you do regularly in your life, whether that is working or driving or managing money or cooking or doing household chores. And so once you have one or more impairments in those activities that you've done all of your life or most of your life, that's when you've transitioned from mild cognitive impairment to dementia. Now, many people will develop mild cognitive impairment as they age. It would be an expected normal part of aging. And with it, about a 10 to 15% transition rate in those people that have MCI into dementia per year. So just because you have mild cognitive impairment does not necessarily mean that dementia is coming, but it is something to monitor for and watch for. There are two other terms I just really quickly want to mention. So they're not, the one is not really a medical diagnosis, but a medical label perhaps. So we also may call people as having subjective cognitive impairment. This is a person that believes that their memory is not as good, or they're having trouble making decisions. These issues aren't really noticed by their family or loved ones. They're still functioning, and we do cognitive tests for them, and everything is coming out normal. Another term for this is the worried well. We don't really know what this means. It could be related to many things: stress, not sleeping, anxiety, whatever the case is. And then there is another term being used more and more, which is mild behavioral impairment. And so Dr. Alzheimer's first patient that was labeled with Alzheimer's disease, her initial symptoms were behavioral and psychiatric in nature, not as much her memory becoming impaired. So if we have an older person that has no history of anxiety, no history of psychosis, no history of depression, that is developing that in their later years, this is a bit of a flag here to start to question, is there something else going on? And I'm sure many of my psychiatric colleagues would agree that it is unusual for someone that's never had depression in their life to start developing it at 65 or 70, outside of, life crises and that sort of a thing. And then in terms of dementia, as you had wanted me to touch on, so dementia is an umbrella term. It is a label as to a level of impairment in their cognition, and then there are branches or subtypes of dementia. The vast majority of those would be Alzheimer's disease, which I think most people would be aware of. But many people have multiple types mixed together. So we would call that a mixed dementia. And so the vast majority of people are going to have both a vascular issue, so vascular changes in their brain, as well as Alzheimer's disease. So that would be the most common type of dementia that we would see clinically. There are other rarer forms that might be alcohol-related dementia, rapidly progressive dementia from Creutzfeldt-Jakob disease, dementia from repeated head injuries, whatever the case is. But dementia is a broad term, and then we hone in and look at subtypes, for which Alzheimer's disease is the best known and most common type.
And is there any way to distinguish between the different kinds of dementias? Is there a blood test or a scan that will definitively say, aha, you have this or this?
I wish that was the case. We may get there. We may get there. So it really depends on a patient's history. Have they been using alcohol significantly over the course of their life? Have they sustained multiple head injuries from playing soccer or boxing? What is the age of that patient? So a patient that is developing behavioral issues or thinking issues in their late 40s and 50s is much more likely to have a dementia type called frontal temporal dementia, whereas somebody in their 60s or 70s that has noticed that their memory is sort of going downhill, but they can still make decisions for themselves, they're still speaking okay, they're more likely to have Alzheimer's disease. So there are a lot of different tests being developed. We're looking to see if we can develop blood-based biomarkers where we can measure abnormal brain proteins in people's blood. These are being used in research studies, and there's hope that they will be released broadly in Canada in the months or years ahead, but we're not there yet. So at the end of the day, dementia is a clinical diagnosis made by me or other clinicians, and we try to support it with evidence, whether that be different types of brain scans or neuropsychologic testing or what have you.
So let me then go back a step into that MCI space. And one of the common questions that came up is, how do you differentiate between normal aging and MCI?
I mean, that is the golden question, I suppose. So it is thought there's between 10 to 15% of people older than 65 have mild cognitive impairment. Our neurons are sliding out of our heads like sand through an hourglass once we're in our 20s. And as we age, our brain loses neurons and shrinks. And so your memory is never going to be as good as it was in your 20s if you're in your 40s, or in your 60s as it was in your 40s, et cetera, et cetera. And so you have to look at the entire picture there of the patient and see, is this to be expected given their age? Is an 85-year-old man that may forget to turn the lights off or to lock the doors, is that really a dementia-looking picture versus somebody that's having trouble, for instance, like using a computer or TV remote, or they were an avid reader, or they loved, renovating their home and working on projects, and they're not doing those things anymore? These are the types of flags I look for, where somebody had interests, passions, things they enjoyed doing, and they've kind of lost that picture. That's where I start to think, this could be a more dangerous MCI picture rather than age-related changes in the brain.
So maybe just circle back to why it's important for us to distinguish between these, or is it?
I think it possibly wasn't as important 10 years ago, but it is more and more important as these new drugs have been developed and are now being approved in Canada. And so these new drugs are targeting patients that are in earlier stages. So it seems that the abnormal proteins in dementia are being laid down in the brain decades before we can detect symptoms. And if we can find and detect the patients in earlier stages, we have a wider window in which we can begin treating them, not just with dementia medications, but with cardiovascular interventions and that sort of a thing. And so it's become much more of an important topic to identify those people that have MCI, as they are more likely to be able to have interventions that work for them or be approved for treatment for these new protein treatment drugs, such as the amyloid monoclonal antibodies that we are having approved in Canada as of the last few weeks.
Well, that's a nice sort of segue then into talking about what's new in the treatment of MCI, early dementia. And so maybe you can expand a little bit more about this area. Have we found a cure for Alzheimer's?
Not yet. Not yet. Okay, so I'll have to go a bit broad here. So years ago, though a clinician may make a diagnosis of dementia, a pathologist needed to do a brain biopsy or autopsy to detect the abnormal proteins that were associated with certain types of dementia. That was the only way to definitively prove somebody had a certain form of dementia. Certainly the clinicians could be accurate within a realm there, but we needed brain tissue to see this. Now we've developed ways, either through testing people's spinal fluid or doing certain types of radio tracer scans, PET scans, we can now see these proteins in people's brains while they are living. And so that means we can now start detecting these issues while people are alive, even before they have symptoms. And this allows for us to then start using medications that we're hoping will reduce the level of those proteins. All of that being said, we know there are abnormal proteins in Alzheimer's disease, and we know we can now reduce the levels of those proteins in Alzheimer's disease. But really, at the end of the day, we don't know why those proteins are getting deposited there for the most part in the first place. So we have a stepping stone after 20 years into a treatment that will allow us to remove abnormal protein buildup, but we can't really state that this is a cure. There was a quote from a science paper that just as removing smoke from a fire does not extinguish the fire, removing proteins from the brain does not reduce the development of dementia over time. So I think it's a very exciting time. We can target people very early, which I think is amazing. But a cure, as it were, we are not there yet. We still do not know why those proteins are forming in some people and causing problems. And in some people, they are formed and they do not have cognitive challenges. So it's a very murky picture. But it's still exciting that we have something that we can do early on, and if it extends life and cognitive ability for a year, 2 years, I think that's a win.
You refer to these evil proteins, and maybe just calling them out. This would be the amyloid protein. Maybe you can expand more.
So within Alzheimer's disease, in autopsies, in brain tissues, we see two types of abnormal proteins. First is the amyloid beta protein, which is floating in our cerebrospinal fluid. But in patients with dementia, it starts to deposit and make plaques in our brains, as well as our blood vessels in our brains. This seems to then lead to development of protein misfolding in what are called tau proteins. And what we then see is this tau turns into neurofibrillary tangles, which really gunk up the works of the brain and cause inflammation. And then this leads to more neuronal or brain cell death. So the hope here is that if we can target the amyloid beta early, this seems to reduce issues of tau protein buildup as well. And our hope is then that the cognitive burden is held at bay and delays progression. We do not really expect to see somebody that has lost their ability to drive or lost their ability to cook food or use a TV remote to regain that ability. What we're seeing is that we are slowing or halting the progression for a period of time.
Right, and so I'm sure that many of our viewers will be thinking, well, beyond what we've talked about, is there anything that we can do to reduce, the amyloid protein or the tau protein floating around in our CSF? Is there, any supplements or foods or anything else that can impact that?
I get asked this question a lot. Now, dietary studies and supplement studies are, for the most part, not performed well, and there's too much variance in people's diets and habits to make concrete statements about take this supplement or eat this type of food. Across vast populations, perhaps, such as with the Mediterranean diet, we can make some inferences. And so the only vitamin I become concerned with is a lower vitamin B12. A low vitamin B12, we need this to make neurotransmitters to help neurons or brain cells communicate with each other, as well as to make the insulative coating around the neurons so that the electrical signals can flow properly. So if I see a low normal and certainly a deficient vitamin B12 level, I'm usually asking the patient to supplement or have injections. There have been a few new studies coming out with lion's mane. It's interesting. I certainly can see why mushrooms can change brain function. We've seen that with psilocybin or magic mushrooms. I usually tell people it seems safe. I don't know that it is improving or slowing things down for you. And you have to make a cost benefit kind of assessment here, because I do find some patients may be going overboard and spending a few $100s a month on supplements where that money could go to a gym membership or a learning session or something that improves their health and cognition in other ways. So if the economics is not an issue, I'm not that concerned, but I don't really have supplements that I specifically say people, you should probably be on this outside of vitamin B12.
Yeah, so let me circle back to the B12. For those people that are madly looking up the My Health Alberta to look at their B12 levels. And this is not a screening test that we normally do, but certainly I'm doing more B12 levels for the reasons that you've talked about. So the lab normal value is 150 for B12. What would you say in a patient that you're worried about neurological compromise? What's the number that you're looking for?
So if the level is actually deficient, then my preference is that patient begins injection treatments to correct the level as soon as possible. I'm always more concerned in strict vegetarians because their vitamin B12 consumption in their diet is much, much less. And just like I'd mentioned, the neurocognitive reserve, you want to have enough vitamin B12 in the tank. So I do think that because it's not flagged as red, many people aren't actually looking at the value of the vitamin B12 level, but I'll see it at 155 or 161 and so on. And it's basically the tank is empty at that point. So if I see that, I ask them to supplement orally. And most of my consults will say a target of over 300 would be advisable to be maintained so that there is some variability, but we're never getting to the empty tank situation. So that's where I usually want it.
Yeah, and just some more information about B12. It is a water-soluble vitamin, so what your body doesn't need, it pees out. So there is a degree of comfort in if you're going to take a supplement, you're thinking about this. If you take B12, and I think 1,000 units is the oral dose that or sublingual dose that this is recommended. If your body doesn't need it, your toilet will accept it. So it's not one of those fat-soluble vitamins that we worry about accumulation. So, so good point. You know, we had a question in the chat, and I want to circle back to the new treatments. You made the point that the new treatments are most effective in early stage disease. You've talked about MCI as being maybe the sweetest spot, but what about patients who've slipped from MCI into Alzheimer's? What's mild disease look like?
Mild disease means that they have at least one impairment in instrumental activity of daily living. You know, maybe they're not driving anymore, or maybe their partner has taken over financial management because bills were getting not paid. But they're still functioning for the most part. And that's a good situation to be in, because if we can extend cognition and quality of life over a year or two and allow these people to remain at home and keep kept at their sort of baseline, their new baseline, I think that's a good target. But if we're at the stage where, you know, patients may have multiple impairments and they need assistance in turning on the TV or using the oven, and we are extending their life at that baseline, we may not be achieving clinically meaningful goals for patients or their families, and only extending life. Let alone at that stage, people will have probably more issues on their MRI scans, like hemorrhages or strokes or that sort of a thing. And so the risk in treating patients at that stage in moderate to late stage dementia goes up, whereas the clinical benefit of using treatments where you are receiving an IV infusion every 2 weeks or monthly, it becomes outweighed, it becomes skewed. So we really want patients that are, for the most part, doing well, their other medical issues are managed, they're functioning for the most part in their communities and home, and we can make a clinically meaningful benefit to their lives at that stage.
So again, it raises that issue that we have to, meaning the medical home has to be able to respond a little bit more structured, formally, and in a timely fashion when patients are self-identifying concerns, recognizing that a lot of people who are concerned about memory, that this may be subjective, it may be something that they're experiencing, but not by others in their circle.
And it speaks to how the cognitive neurologists and geriatricians have made a statement that, you know, the patients should have a family member, close loved one, long-term friend with them for these assessments, because it is very hard to, how do you ask somebody, what are you forgetting? How will they remember what are they forgetting? So having somebody there that knows the patient well, can provide their insights and say, actually, I'm seeing this more and more, or actually, I don't think they're doing that very often. It is a huge benefit and really makes it less murky for everybody involved. So having somebody with the patient that can provide that secondary history is pretty much essential at this point.
Want to go back to something that you alluded to in why we don't treat patients, older patients, with these medications, these new medications, and right now there's one that's available through Health Canada, but another one on the horizon. Um, well, so what's the risks? I said, B12, yeah, pee it out if you don't want it, if your body doesn't use it. What are the risks of these new anti-Alzheimer's medications?
So there are some minor risks. So every 2 weeks or month, depending on the medication, you will go for an infusion through your vein. It usually takes an hour, maybe a bit longer, and people may develop what are called infusion reactions. And this can happen from anything that's being put into somebody's vein. It could be sweating or headache or feeling short of breath or whatever the case. If we see this type of issue, we may stop the infusion for a while, provide a drink, calm them down, whatever the case is. And if they feel better again, we can restart the infusion. So pretty minor things. It may just extend the time that it takes for the infusion to go through. However, we have seen issues in patients where they develop what are called ARIA. So ARIA, these are amyloid-related imaging abnormalities, and we classify them as either edema or brain swelling, as well as hemorrhaging or brain bleeding. In a majority of patients, they will not know that they are having swelling of their brain or bleeding in their brain. However, in some patients, these can be fairly significant, and they may notice that they're having headaches, or they're more confused, or they're having trouble walking. And in some cases, in these studies, we have seen people develop seizures, comas, or have died from the swelling or hemorrhaging. So we really need to be careful in selecting the correct patients for this so that we reduce the risk of that happening to them. And there are a lot of questions regarding, we touched on cardiovascular health, which just as dementia, it increases in risk as people get older. And so if you've had a stroke, if you've had a heart attack, and now you require treatment with antiplatelet drugs, usually multiple, or treatment with anticoagulant drugs, your risk of bleeding is higher, and that is a no-go for treating a patient with a drug that may cause bleeding in the brain. And we have questions at this time regarding, if we have started a patient on this drug and then they develop a heart attack later on, what do we do with that patient? Do we put them on a drug that may cause bleeding elsewhere and take them off the Alzheimer's drug? It is a bit murky, and we need to see how people do over time in sort of observational and retrospective studies with that. So there are some risks. These medications have gotten better in terms of the overall risk, but we must be very selective and choose the right patient for the right treatment, or there can be bad consequences.
So, Landon, if I can just summarize a few of the things that you've said, just to make sure that I've got it straight. The good news is we've got therapies which can change the course of this devastating disease. But you've got to get patients early in the history of cognitive decline. This isn't oh yeah, take the script down to your pharmacy. There needs to be investigations, MRIs, lumbar punctures, getting some of that spinal fluid, and then a series of injections, infusions, and follow up by MRI, looking for any of these potential complications. And what that does is it extends the well period or decline, or slows the decline. Does that capture?
Yeah, that's exactly what we're looking for. We're hoping that these may extend their cognitive abilities. It will not improve their cognitive abilities. In most patients, we saw very modest changes, if anything, in their testing, their paper testing, not in their day-to-day lives. But if we can extend their quality of life and cognition, allowing them to remain home for a year or two, that is a significant benefit to the patient and their family and lowers costs for the healthcare system in terms of placement and nurse care and all of that. So it is a very exciting thing, but we just have to be careful with who and what we're targeting with these treatments.
So Landon, this has been excellent in terms of giving us sort of the really up-to-date science and what's happening. I'm going to give you a break, but bring you back. We've got some great questions that have been submitted and also on the chat. So hang tough for a few minutes. I'm going to ask Shauna to come on and maybe talk a little bit more about what we can expect CVFP to be doing differently in this brain health space. Shauna, take it away. What the heck's going to change in how our medical home supports patients around their journey with brain health?
Yeah, thanks, Rick. First of all, I want to thank everybody for joining us tonight. I know that your time is precious, and we're so grateful that you spend some of it with us. Tonight has been full of a lot of juicy information, and I just want to recap our journey a little bit because I think even this webcast is a resource for our patients, and that's the first thing we'll start with. So we've talked about what is brain health. We've talked about why it matters and how preventable it is and how to prevent things like dementia in our lives. We've also talked about how we identify it early and the kind of new treatments that are available. And that's really our jumping off point now is we've got some new therapies available. And so we really need to develop some work between primary care and neurology to make sure that our patients can get access to these therapies and access to tools for prevention and navigating dementia, both patients and family members. So we've got a brain health project at CVFP. We're working to develop some tools and pathways for our patients. We're working with Dr. Perlett and his team to make sure that we can create a partnership that will be helpful to our patients. So what you're staring at here is something that's in development. So this is all hot off the press. So of course we want to make educational resources available to our patients. So we're creating a My Brain Health checklist for you. This is just a little snippet of it, and you'll see it contains some of the information that we chatted about tonight. So certainly feel free to screenshot this if you really want to keep this, but we'll have an extended resource on our website available to you. So one of the first things you can do is make sure that you're a subscriber to the CVFP community. So if you're not, many of you are, because that's how you would have found this webcast. But if you're not, head to our website, click on the community page, scroll to the bottom, and sign up to receive our offers. And all of our updates. I really want to stress that we're still working on a lot of these resources, so we'll get them to you as soon as we can. They're not quite ready yet. But if we go to the next slide, let's just talk about some of the things you can do in the meantime while the CVFP team is working to put these things together. This is going to be sort of a bit of a recap too of some of the things you heard tonight. Of course, not on this slide, a few things that you can do proactively is get a hearing test. And like Nurse Alex says, you can find those free at a local hearing clinic. You can also see your optometrist to have your vision checked annually. And I think the other important thing is know your numbers. So if you're unsure about your cholesterol or your blood sugar, make sure that you go to myhealth.alberta.ca. If you're not already signed up, you can to access your own medical records, but there you'll find your numbers. And certainly if you haven't had that done in the last year, make sure to call us and we can work with you to get that done. If you don't know your blood pressure, your community pharmacist is a great resource for that. Not only can they take your blood pressure for you, but they can explain what it means to you. And if you have a certified monitor, you can also do that at home. And then for those of you who are really interested in lifestyle changes like nutrition, activity, managing sleep or stress, the Alberta Healthy Living Program is a great option. They have lots of resources and classes that you can sign up for and take. And the best way to access them is actually just to Google it. It's an Alberta Health Services program. Just Google Alberta Healthy Living Program and you'll find Calgary-specific resources.
Shauna, I wonder if you could just give a little bit of teaser about how we might be thinking about putting all these might, maybe, could be, this whole artificial intelligence, AI. How might we use that in this brain health initiative?
Yeah, a great question. So, I think in medicine in general, we're really looking at ways that technology can help support the team and patients. So we're exploring with a local partner how we might weave artificial intelligence, AI, into tools we already use. So in our Bright Squid and secure messaging platforms, so that if you have questions about your brain health or you want to engage with our team, we will have an AI tool that's actually developed by the CVFP team, where all of the information you get through that option is created and approved by the CVFP team. So you'll get information about sustaining and supporting your brain health that you can trust. We know that this webinar and creating this conversation, it's going to spark questions from you and your loved ones. And so just know that as soon as the program is launched and as resources become available, we're going to make sure that we get those out to you. Again, just want to really thank you for your time tonight. Really looking forward to the Q&A. Rick, is there anything else you have for me?
Yeah, no, Shauna, thanks. Thanks as usual for your ongoing leadership in this space, and it's great that you're able to use all of the knowledge that you've gained doing your master's in the last couple of years to support us. All right, so let me turn back to Dr. Perlett, and question number one, and this has come from a couple of people. What about the genetics? Both of my parents had Alzheimer's. Am I at increased risk? Is there a way of testing for that?
So that is a very, very common question. And for the most part, I will just say no. So if you have a primary or first degree relative, sibling, mother, father, what have you, that has been diagnosed with Alzheimer's, your risk compared to somebody that has no first degree relative with dementia is higher than the general population. But that does not mean that you are going to develop dementia simply because your mother or father had that. Now, there are genetic disorders or genetic mutations which we see will cause people to develop Alzheimer's disease, but they are quite rare. We see this less than 1% of the time. Most of the time we are seeing that is in patients that have what we call young onset Alzheimer's disease. So these are symptoms that are developing before the age of 65. And even in that setting, it is still fairly uncommon to find a genetic mutation associated with Alzheimer's disease in that way. There are also the apolipoprotein 4 gene markers that everybody carries two from each chromosome. ApoE4 is the one associated with a higher risk of developing Alzheimer's disease, whereas ApoE2 is associated with the least risk. And if you are unfortunate enough to develop or to have inherited ApoE4 from both parents, your risk of developing Alzheimer's disease is higher, but it does not mean you will develop it for sure. So that is part of what will be done for the screening for these new Alzheimer's drugs, is looking at the ApoE4 markers, not so much the other much rarer genetic mutations.
So if you've gone on to 23andMe or you've subscribed to it, and I think, is it ApoE that they measure in that?
Correct.
What kind of information would that give you?
So you would know, so there are three forms: ApoE2, ApoE3, ApoE4. You would know, do you have any ApoE4? If you have one, your risk is higher. If you have both copies from both parents, your risk is much higher. That is the worst scenario. 3 is kind of neutral. It doesn't seem to convert risk one way or another, whereas 2 seems to lower the risk. So if you are fortunate enough to have ApoE2 from both parents, your risk of developing Alzheimer's disease is lower, but you still could develop Alzheimer's disease. It is not zero. Right. So that's what you might see as part of the 23andMe, because it's a huge panel of genetic screen.
And of course, this speaks nothing to the other types of dementia that we've mentioned. And
correct.
That gives me a bit of a segue into my buddy Howard's question is maybe talk a little bit about frontal lobe dementia and how that may present as being different than Alzheimer's type dementia, or are they the same thing?
Sometimes they may look very similar, but the patient population is going to be a bit different. They're going to be younger. Usually symptoms are developing maybe late 40s, in most cases in their 50s. And the classic picture is somebody that is developing personality or behavioral issues. They are irritable and aggressive. They are rude to people. They may have changes in their diet and they just crave sugar, or they keep shoving food in their mouth and they're quite rude at the table. They're kind of lost their manners in a certain way. Or they may have no interest in things. They don't care what's, you tell them their pet had died and they have no emotional display regarding that, or they do something, mean or rude to somebody, and that it's no big deal. So what we'll normally see is some sort of behavioral change that doesn't match very well with a psychiatric or mental health disorder. And in less often, we might see patients that start to develop issues speaking. So their speech is very broken. They can't get the words out, or they start to lose meaning of the words. Their wife asks them, "Can you go get me an apple from the fridge?" And they say something like, "An apple? What is an apple?" Like they don't know what those words mean, or they're having trouble stating the words out loud. So those are the typical things we might see in a patient that's developing frontal temporal dementia. Oftentimes they are much younger.
Yeah, tragic disease, and nothing that the new treatments have to offer that condition.
So it is a tauopathy. So the protein in frontal temporal dementia is for the most part tau. They are looking at disease-modifying therapies targeting tau. None have been overly successful so far, but there is hope. There is hope.
Mikali 2025 asks specifically about the subtypes of psychiatric diagnosis, mental illness, and I hate those terms, but so depression versus anxiety versus ADHD. Ingen has made some comments in the chat, but is there any sort of specificity and risk amongst the mood disorders or the attentional disorders as risk factors for dementia?
It's a gray area. I always say at the end of the day, whether this is dementia or cognitive impairment, if your mental health is worsening, there are so many treatments, way more treatments for these issues than we have for dementia. And so they should be looked at and selected for counseling or antidepressant treatments or even antipsychotic treatments. In terms of ADHD, there is some data showing that perhaps there is an elevated risk of developing dementia later in life in comparison to those without ADHD. But we're also seeing data showing that patients with undiagnosed ADHD tend to have worsening symptoms as they get older if they're not on treatment, as well as perimenopausal and postmenopausal women. If they have not been diagnosed with ADHD, their symptoms tend to get worse. And we see that during their menstrual cycle as well. So there's an interplay there with hormone levels and their attentional deficits. So a very murky question. Whether or not somebody has a cognitive impairment, if they are developing depression or anxiety, better to treat it than to not, in my opinion.
Yeah, and mental health is really the bread and butter that I see in my practice, and lots of discussions with patients. Most of it, is centered around functioning now, but I think what I'm hearing is that there are implications, or can be implications, for brain health down the road, and I think that fits with a lot of the other evidence that is saying that early and aggressive management of patients with aggressive or with anxiety and depression, can really change the trajectory. So maybe there's some themes that are emerging in that.
Let me just phrase it as this. If you have depression and you have little interest in doing things, you're not exercising anymore, your diet is going off the rails, all of these other modifiable risk factors fly out the window. And so why not treat the depression so that they have more interest in engaging in family and socialization? They have an interest in getting out of bed and getting some exercise. treating their depression will lead to downstream effects in their overall health. And so I think it's an important topic to look at and treat with, whether it's medications or therapy or what have you.
Yeah, no, totally agree with that. Again, comment in the chat that, there are so many people that suffer from chronic depression and despite treatment into their middle and later decades. And so I think it's, while we have great success in so many ways, that have to also acknowledge that just like with Alzheimer's, we don't always have perfect treatments. So doesn't mean that's not worth reflecting on. There was a question about routine screening. I mean, we're checking blood pressures, we're checking cholesterols and sugars. Should people come in for a regular screening, neurological examination, or a cognitive screening? Should that become the new normal?
I think at this time, no, I don't think that's absolutely required. There may be some debates as to whether at certain ages you need to do a driving examination or whatever. I'm not going to touch that topic right now, but at this point, no. In the future, if we have access to these blood-based biomarkers where we can measure amyloid beta levels or tau levels or alpha-synuclein levels in the blood, that may be the screening tool where we look at people. We can send a blood test in somebody that's never even thought of dementia at 45 years old, and we say, oh, this level is elevated. Then I think we're going to see more of this. Oh, we should do a screen now. We should maybe have them bring their partner or brother into clinic and see if they've noticed any issues. But we are simply not there yet. You've mentioned this as a paradigm shift. Even though the new medication is approved, it requires a vast amount of resources, including MRI scanning time, ability to perform invasive procedures like lumbar punctures, having nursing and administrative staff to do infusions for people. So at this point, no, I don't believe an annual cognitive screen is necessary unless the patient or the family member is voicing concerns. Then, of course, you would go ahead with that.
Yeah, I see that another question in the chat, which I'll add to Ingen's comments. The question is, is increasing cholesterol not something that happens normally with age, and sort of like hair loss in some people. We know that kidney function, I loved your discussion about, the sand slipping through the hourglass, the neurons starting to, I would say I've got a sieve, not an hourglass. But anyway, that's so sugar goes higher with age, kidney function reduces, cholesterol goes up. And guess what? Death increases with age too. And we know.
Slippery slope out there.
It is. But we know that there are things that we can do, and certainly lowering cholesterol through lifestyle, but particularly in those high-risk patients with statins. It's just been shown through many studies how protective this is. So yes, there are things that inevitably deteriorate with age, but those are often associated with comorbidities. Listen, I've got one question remaining that I'll bounce off you, and then I'll just get our panel to quickly give us one piece of wisdom to leave with. What happened to the old medications, the Ariceps and those oral medications that were around years ago? Are they not still being used? Is there a place for them?
I use them all the time. I find them to be fairly well tolerated in most people. I will say in the vast majority of patients and their family returning, they will tell me, I don't really notice a big difference in dad or my sister. And I'll say to them, well, I don't have two versions of you. one that takes the medication and the other that doesn't, and then they come in 6 months, and I can say, this medicine really changed the trajectory here. So the thought is we can use these medicines to increase neurotransmitters such as acetylcholine and reduce neuronal loss by blocking or activating NMDA receptors within the mantine. These are still fairly safe, fairly well tolerated medicines. And they still are a part of our tool belt, and they still should be used as long as it fits with the patient's symptoms and there are no other concerning comorbidities. And in most of these new monoclonal antibody studies, as long as they've been on these treatments for a while, they are more than able to have all of these treatments ongoing. So I think it's still an important tool in the tool belt. Again, the effect is modest. Every once in a while, I will hear that maybe grandma has more focus and can pay attention to things, or that uncle is not asking as many questions, or that auntie is less irritable and less depressed. And I consider that a win if it's just a once or twice daily medication, and it can kind of hold the line, as it were, for maybe a year or two. Regardless of whether a patient takes these medications, we are going to see further decline. The hope is that it is a slower decline.
No, good place to end and set realistic expectations. JR, any last bit of wisdom that you want to share on this topic before we let everybody get back to snow shoveling?
I find myself saying more than once a week, if I could prescribe one thing for every condition for the rest of my career, it might be exercise. So I think I want to focus on the things that are in our control, and really tie them to it's good for your brain. If you're worried about your brain, think about all of those things that we say. So we'll focus on that. And I appreciate everyone coming on the journey with us as we do test a process to maybe do some early case finding, and help make it easy for us to connect people with the care that they need.
Right on. Thanks so much. Shauna.
Yeah, thanks, Rick. I think I'll pick up on what JR was saying. For me, as a non-clinician coming into the brain health space, and as Rick said, I started learning about this a couple of years ago in a master's degree. I was shocked at how much we can do to protect our own brain health. And I think, Janet talks about if she could do nothing else, it would be to tell people to move. And some practical advice I got from one of our physicians was, a lot of times we think movement means I need to run a marathon or I need to do an hour workout every day. And it actually doesn't. Movement can be anything that you can do regularly. So that might be walking for 10 minutes or something like that. But pick something that you can do regularly that feels sustainable and just start there.
Great advice. Nurse AJ, are you able to give us the nursing wisdom?
Absolutely. And truly, I think what Shauna and Dr. Reynolds are saying is really valuable. You can know all the information and know what those steps are, but you need to act. So being an active participant in your health means to act, to take those first steps. They don't have to be all of the steps at once. We can only climb one step at a time. So really, start working, seeing the places where you can make the changes and just start acting on them. Reach out, talk to a friend, get active, go for a walk, read a book, and maybe grab a fruit and put down the wine. Not me, but other people.
Yes, other people.
Yeah, other people.
And Landon, lots of pearls that you've given us already. What do you want to leave with tonight?
I guess maybe a question I get asked a lot are the phone games. Which phone game should I be playing? Look, I'm an avid gamer. I don't know that playing video games has made me smarter or better at anything else outside of video games. So I just tell people you want to treat your brain to new experiences. So aim for, I don't know, once every week, once every 2 weeks. Go for a hike in a part of the mountains you've never been to. Take a Brazilian cooking class. Go for a waltz lesson. Uh, Learn a new board game with your family. Do something new that your brain has not done before, because that's when your brain is working the hardest. That's where it will make more mistakes and learn better. That is when your brain is happiest. So home game is fine. An experience that is new and novel and with loved ones and friends, that is what the goal should be.
Great. I'm not gonna sign up for those Brazilian cooking classes, but I take your point. I'll find something else. Listen, guys, thanks so much to those of you who have joined and stuck with us. Our amazing presenters, great stuff. A special shout out to Landon and his colleagues at ANC for supporting us in this project. Behind the scenes, Patricia, who makes us all look good in many ways. Trevor, who masters the AV, and Meredith, who bought subs for us to eat tonight and does all the great stuff with email communication. Thanks, everyone. This will be on the website tomorrow. More to come. Happiness and health.